Good afternoon, dear students.
Good afternoon, sir.
Please switch off your microphones and we'll start our lecture. Today, this is the final lecture in pulmonology, and today we'll talk about lung abscess and bronchiectasis. You shouldn't write yourself in the chat. You know that now we know automatically who is present. In the chat, you can type your questions. Okay, lung abscess. Definition. Lung abscess is a cavity containing pus and necrotic debris. Lung abscess formation usually reflects infection with an unusual microbial burden, for example, acute aspiration, especially virulent organisms such as Staphylococcus aureus, and failure in microbial clearance mechanisms, for example, bronchial obstruction. Epidemiology. Most lung abscess involve the indigenous flora of the oropharynx. So we talked already that pneumonia, lung abscess, this is disorders not actually contagious, that usual microbes which live in our oral cavity, in our pharynx, may cause such disorders. Abscess involving Staphylococcus aureus or gram-negative bacilli are most often nosocomial. What we are talking about, again, when we discussed hospital or nosocomial pneumonia, I told you that germs are different. And in case of lung abscess, also such very aggressive germs as Staphylococcus aureus, gram-negative bacilli, this is usually germs from hospitals. And abscess involving Staphylococcus aureus and gram-negative bacteria most often nosocomial or happens in hospitals. Septic pulmonary emboli, usually due to Staphylococcus aureus, primarily in intravenous drug abuses with tricuspid valve endocarditis. No, recreational drugs is a big problem in all countries, and you studied cardiology, you know what has been endocarditis, bacterial endocarditis, and abscess may be as a result of septic pulmonary emboli from actually tricuspid valve endocarditis caused by Staphylococcus aureus in intravenous drug abuses. Etiology. So we know conditions that predispose to lung abscess. And this includes any causes of aspiration or reduced ciliary action, such as renal ciliary action, that's in our bronchi, epithelium covered with ciliary, which clean our lungs, which clearance mechanism, usually we tell. And what may happen? No, reduced levels of consciousness. Reduced levels of consciousness, of course, predispose to aspiration and may lead to development of lung abscess. Alcoholism. No, alcoholism also reduces levels of consciousness, and that's why also it reduces immunity. That's why it's also may predispose to development of lung abscess. Seizure disorders, not the same. General anesthesia. You know, when we perform some surgery, we do general anesthesia. And this is also reduced levels of consciousness. That's why it may predispose to aspiration. Cerebral vascular accidents, drug addiction, dysphagia, esophageal reflux, no mechanical interference with the cardiac sphincter, such as caused by nasogastric tubes and endotracheal intubation. So again, you see that actually in many cases, lung abscess, this is a result of other disorders, of hospitalizations, what may finally cause such aspiration and finally lead to development of lung abscess. Now what else? Or other sources of infection. For example, periodontal diseases, gingivitis, sinus infection, bronchiectasis provide a source for anaerobic infections and other important backgrounds factors. So again, not only typical germs may cause lung abscess, but if someone suffers from other inflammatory disorders which happened in oral cavity or in lungs already, like bronchiectasis, it's also predisposed to development of lung abscess. Another cause of lung abscess is septic pulmonary embolism, most commonly with Staphylococcus aureus, most commonly in intravenous drug uses. We talk about this. So, how actually microbes may reach lungs to cause lung abscess? First, through bronchial tree, and we talk about microaspiration, and second, with blood. Yeah, with blood, like septic embolism, and the main source of such emboli, this is intravenous drug abuse patients with bacterial endocarditis, or even without bacterial endocarditis. People who use drugs, they use dirty syringes, needles, and that's why they introduce these germs, very aggressive germs, into their blood flow. And finally, it may cause lung abscess. Any necrotizing pneumonia can also present with areas of abscesses. So we talk about pneumonia. Pneumonia, this is inflammation of lung tissue. And in case of very aggressive infection, pneumonia may change, or may, in this case, we may say that abscess is a complication of pneumonia. Abscess may be complication of severe pneumonia with necrotization of lung tissue. No, in this case, we talk about lung abscess. Remember, I told you that if destruction, if cavities, in case of pneumonia, less than 2%, we talk about necrotizing pneumonia. But if size of abscess of cavities becomes more than 2 centimeters, okay, this is already lung abscess as complication of pneumonia, of acute pneumonia. When bronchial obstruction develops distal to a pulmonary neoplasm, drainage is difficult and abscess formation is common. Again, if patients suffer from cancer of lungs, this cancer growing block normal drainage, so removing all this stuff from bronchi, no, it may cause actual abscess formation too. For causes of abscess, however, diabetes, malignancy, other immunocompromising conditions are common predisposing factors. Again, we should have two actually factors. First, this is germs, and second, this is low immunity, because in healthy and strong person, immune system easily eliminate, easily kill all germs, and abscess never happens. So low immunity, which may be a result of diabetes, cancer, no other immunocompromising conditions, no also may predispose to development of lung abscess. Pathogenesis, various types of aspiration-related pleuropulmonary infection, pneumonitis, the initial stage, necrotizing pneumonia, multiple excavations less than 2 centimeters in diameter, lung abscess, one cavity is more than 2 centimeters in diameter, and empyema should be considered as one process with continuum of changes. Again, pneumonia, necrotizing pneumonia, then lung abscess, then empyema of pleura. This is just stages of one process. This is just stages of one process. A prediction for infection independent segments is seen, particularly the posterior segments of the upper lobes and superior segments of the lower lobes, but the location of the abscesses depends on gravity and the position of the subject. So what we are talking about, that usually abscesses happen in some definite sides of the lungs. There are some segments of lungs because of mechanism of aspiration, depending on gravity, so gravitation, and position of the subject. Now, for example, when patient lying on a back, you see aspiration occurs into the superior segment of the lower lobe. When patient lie on the back, if patient aspirate, germs move, and occupy superior segment of the lower lobe. If patient lying on side, aspiration occur in the posterior segment of the lower lobe. So this is just mechanics, the way which position and gravity leads to help actually aspiration reach one or another segment of lungs. Endotracheal tubes impair coughing, impede pulmonary clearance mechanisms, and allow leakage of oropharyngeal secretion into the tracheobronchial tree. Now you know that all these intratracheal tubes, when they what does it mean? This is ventilation, artificial ventilation. Now you know about COVID, that in severe cases, patients, doctors, they use ventilators for artificial ventilation of patient lungs. But ventilation itself, due to actually these endotracheal tubes, may cause development of pneumonia. And by the way, this is worldwide statistics. If patients with COVID infection need ventilation, probability of surviving is only 10%. So out of those who are on ventilation, 90% died, only 10% recovered. Fecal particulate matter and foreign bodies are not easily removed and can produce bronchial obstruction and atelectasis. Again, if patient aspirates something, no, of course, it may cause blockage of normal airflow in bronchi, decrease actually cause bronchial obstruction, and finally may predispose to development of lung abscess. In pneumonia following aspiration of gastric content, gastric acid and enzymes are the primary offending agents. So what we are talking about, that in some cases, patient who is heavy drunk, or in case of anesthesia or some seizures, can aspirate vomiting mass. And aspiration of vomiting mass contain acid, contain germs, and of course it causes destruction, contain enzymes. Acids and enzymes destroy lung tissue and prepare these destroyed tissues for infection. And that's why actually it may cause very severe lung abscess. Subdiaphragmatic infection may extend to the lung by way of lymphatic vessels, directly through the diaphragm, or by way of the bloodstream. So in this case, patient may have some infection in his abdominal cavity. For example, subdiaphragmatic. No? On the right side, we have liver. And if we have some abscess in the liver, this or some inflammation, bacterial in the liver, it may be spread to lungs through diaphragm, with lymph, directly with blood, and may cause actually development of lung abscess too. So clinical manifestation. Relatively insidious onset of infection is seen in many patients. Additional clues are involvement of dependent segments of lung, predisposition to aspiration, and often periodontal disease. So when we should think about possibility of lung abscess. After 1 or 2 weeks, tissue necrosis with abscess formation or empyema occurs. Following cavitation, putrid sputum is noted in 50% or more of patients, and hemoptysis may be seen. Weeks to months of malaise, low-grade fever may be associated with cough, weight loss, and anemia. This is main clinical manifestation of lung abscess. Now, the most typical, this is specific purulent, very offensive sputum, sometimes which contain blood. Why? This is necrosis of lung tissue, destruction of lung tissue. And that's why it may lead to development of bleeding, and actually necrosis lead to production of very offensive pus, the purative sputum, offensive purative sputum. On occasion, the picture is acute with fever, malaise, cough, and pleurisy. So we may have two actually presentations of lung abscess. First, I told you more or less insidious when the disease develops slowly. And second, it may be acute with high fever, with coughing, with pain, pleurisy, with weakness, malaise. Patients with lung abscess due to infection with Staphylococcus aureus or gram-negative bacilli are those with secondary lung abscess, and those with secondary lung abscess due to septic pulmonary emboli may have a more fulminant course. So what we're talking about? So if it's due to pulmonary emboli abscess or due to very aggressive Staphylococcus aureus or gram-negative bacilli, which happens usually in hospitals, the development of the disease may be fulminant, so very fast progressive, very fast progressive. Diagnosis. Classic radiographic appearance of lung abscess is a cavity with an air fluid level, with or without surrounding infiltrate. In some patients, however, repeat chest radiographs or computer tomographic scanning may be needed to detect the cavity. A similar radiographic appearance can be seen with a variety of conditions other than bacterial lung abscess, so definitive bacterial confirmation is required. Now, again, this is picture, what we can see. Left upper lobe, you see left upper lobe. In the left upper lobe, we see cavity. Yeah? So air fluid level, you see this is air fluid level. The cavity with air fluid level. This is lung abscess on X-ray. Prevention. In the case of gross aspiration, immediate clearing of the airway by postural drainage and suctioning, preferably by bronchoscopy, is important. So if you know that someone aspirates vomiting mass in big volume, what does it mean postural drainage? It means the patient should find some posture to expel this vomiting mass or what was aspirated. Or you can even use bronchoscopy, the specific special devices like fibroscope, which can reach faraway parts of bronchi and use special solutions, just clean, remove all this bad stuff from lungs. This way you can prevent development of severe inflammatory process and development of lung abscess. Prognosis. The most common complication is emphysema, with or without bronchopleural fistula. So what's happened? That actually this cavity with pus may open into pleural cavity, and the result will have emphysema of pleura. Spillover of pus from a large lung abscess sometimes leads to spread of infection and even to asphyxiation. So when patients expel huge amount of sputum due to aspiration, this actually pus may reach other parts of lungs and may cause development of extra abscesses. Now, other complications are rare, including brain or other distal abscesses. So you know that this pus from lungs may be spread with blood and reach, for example, brain, causing brain abscess or kidney abscess. No generalized infection may happen. Severe hemorrhage may happen when this destruction of lung tissue reach some big vessel. It may cause severe hemorrhage. Pulmonary gangrene, very serious complication. Pulmonary gangrene may also result, may also happen in patients with lung abscess. Okay, next topic. Next topic is bronchoectasis. Next topic is bronchoectasis. Definition. Bronchoectasis is an abnormal and permanent dilatation of bronchi. The abnormal and permanent dilatation of bronchi. It may be either focal, involving airways, supplying a limited region of pulmonary parenchyma, or diffuse, involving airways in a more widespread distribution. The bronchial dilatation of bronchoectasis is associated with destructive and inflammatory changes in the walls of medium-sized airways, often at the level of segmental or subsegmental bronchi. The normal structural components of the wall, including cartilage, muscle, elastic tissues, are destroyed and may be replaced by fibrous tissues. So we have some destruction process, inflammatory process in bronchi, which cause destruction of normal tissues and substitution with scars. What is fibrous tissues? This is scars. Dilated airways frequently contain pools of thick, purulent material, while more peripheral airways are often occluded by secretions or obliterated and replaced by fibrous tissues. Additional microscopic features include bronchial and peribronchial inflammations and fibrosis, ulceration of the bronchial wall, squamous metaplasia, so substitution of normal bronchial epithelium by squamous epithelium, the squamous plant epithelium, squamous metaplasia, and mucous glands hyperplasia. Mucous gland hyperplasia involves all kinds of inflammation. We have growth of these glands, which they produce a lot of sputum. The parenchyma, normally supplied by the affected airways, is abnormal, containing varying combinations of fibrosis, emphysema, bronchopneumonia, atelectasis. What we're talking about again, of course, if we have damaged bronchi with atelectasis, these bronchi can't provide normal airflow, they can't provide normal oxygenation or ventilation of parts of lungs, which ventilate through these bronchi. As a result, in lung tissue, we also may find changes, fibrosis, emphysema. That's why, again, bronchiectasis is not problem of bronchi. If it's happened, if bronchiectasis happened, this is problem for all parts of lung tissues. As a result of the inflammation, vascularity of the bronchial wall increases with associated enlargement of the bronchial arteries and anastomosis between the bronchial and pulmonary arterial circulation. So continuous inflammatory process also damage vessels. Vessels becomes wider, bigger, but what may happen? They create anastomosis, they create shunts between bronchial and pulmonary arterial circulation. Why it's important and dangerous? Because it means that blood from veins can easily reach arteries. As a result, this blood don't pass through capillaries, which oxygenated with in alveoli. That's why blood just finds shortcut, and instead of oxygenation, without oxygenation, return to circulation. As a result, it may lead to problems with actual oxygenation of blood, and as a result, with functioning of lungs totally. So there are three different patterns of bronchiectasis described by Reid in 1950. So we have cylindrical bronchiectasis, we have varicose bronchiectasis, and we have saccular or cystic bronchiectasis. The cylindrical, varicose, and saccular or cystic. Now this is of course dependent on the shape of bronchiectasis, shapes of bronchiectasis. Cylindrical bronchiectasis. In cylindrical bronchiectasis, the bronchi appear as uniformly dilated tubes that end abruptly at the point of the smaller airways obstructed by secretions. So now again, on X-rays, this cylindrical bronchiectasis look like a cylinders. That's why they're known as cylindrical. In varicose bronchiectasis, affected bronchi have an irregular or beaded pattern of dilatation resembling varicose veins. Some irregular pattern, narrowing, widening, like beaded or actually varicose veins. Just imagine them, varicose veins, and bronchiectasis look like as varicose veins. In saccular or cystic bronchiectasis, the bronchi have a ballooned appearance, and ballooned appearance at the periphery ending in blind sacs without recognizable bronchial structures distal to the sacs. You see, in all cases, what we repeat, that we have bronchiectasis and distal from bronchiectasis, everything damaged. We don't see normal bronchi, we don't see normal lung tissue. That's why, again, bronchiectasis is not only problems of bronchi, this is problems of all components of lungs. So, why bronchiectasis happened? Etiology and pathogenesis. Etiology and pathogenesis. Bronchiectasis is a consequence of inflammation and destruction of the structural components of the bronchial wall. So, this is result of inflammatory process. Infection is the usual cause of the inflammation. Microorganisms such as Pseudomonas aeruginosa, Haemophilus influenza, produce actually pigments, proteases, other toxins that injure the respiratory epithelium and impair mucociliary clearance. The host inflammatory response includes induced epithelial injury, largely as a result of mediators released from neutrophils. Now, this is as usual. If bacteria appear, neutrophils start fighting with bacteria, bacteria release some toxins and enzymes, neutrophils release toxins and enzymes, and as a result of this, battlefield is completely destroyed. In our case, battlefield, this is actually our bronchi. That's why result of such infections and fighting with such infections lead to destruction of bronchial wall and may predispose to formation of bronchiectasis. Adenoviruses, influenza viruses are the main viruses that cause bronchiectasis in association with lower respiratory tract involvement. No, we still don't know about coronavirus because again, we don't have enough time. Maybe coronavirus also may cause development of bronchiectasis, but we'll see this in future. We'll see this only in future. Tuberculosis. Tuberculosis can produce bronchiectasis by necrotizing effect on pulmonary parenchyma and airways, and indirectly as a consequence of airways obstruction from bronchostenosis or extrinsic compression by lymph nodes. So again, tuberculosis also may cause development of bronchiectasis. Slowly growing endobronchial neoplasms, it means cancer, such as carcinoid tumors may be associated with bronchiectasis. Foreign body aspiration is another important cause of endobronchial obstruction, particularly in children. Now, airway obstruction can also result from bronchostenosis, from impacted secretions, or from extrinsic compression by enlarged lymph nodes. So what we're talking about, all cases when we have some obstruction of bronchi, it may lead to development of bronchiectasis. The primary disorders associated with ciliary dysfunction, termed primary ciliary dyskinesia, responsible for 5 to 10% of cases of bronchiectasis. It's interesting. This is condition when cilia becomes dyskinetic. Their coordinated propulsive action is diminished and bacterial clearance is impaired. The clinical effects include recurrent upper and lower respiratory tract infections such as sinusitis, otitis media, bronchiectasis. So this is some condition when we actually don't exactly know why, but these ciliaries, they don't work proper way. They are dyskinetic. They can't produce this propulsive action. As a result, we have impaired clearance, and the result, bronchiectasis may develop. Non-infective causes. Non-infective causes. Some causes of bronchiectasis are associated with exposure to toxic substances that incites a severe inflammatory response. Now, for example, inhalation of toxic gas such as ammonia, aspiration of acid gastric content through toward the later problems is often also complicated by aspiration of bacteria. Now, in these cases, what we have? First, we have damage of bronchi with something, gas or acid, but of course, then bacteria appear and we have complex of damaged tissues with infection. No, this is like for development of lung abscess we just discussed. Alpha-1 antitrypsin deficiency. Usual respiratory complications at the early development of pan-axonal emphysema, but affected individuals may occasionally have bronchiectasis. We talk about alpha-1 antitrypsin deficiency when we talk about COPD, and this is 1% of cases of COPD due to this deficiency. And I told you that usually we have destruction of fine alveoli in lung tissue, but actually bronchi also may be destroyed. As a result, it may lead to development of bronchiectasis. Okay, clinical manifestation. Clinical manifestation. Patients typically present with persistent or recurrent cough and purulent sputum production. Two main signs, please remember. Two main signs. This is cough and purulent sputum production. Because remember, in COPD, for example, sputum is not purulent, it's just mucus, and only when we have exacerbation with bacteria, like bacterial exacerbation, infective exacerbation, sputum becomes purulent. In case of actually bronchiectasis, bacteria all the time live in this bronchiectasis. As a result, usually patients produce purulent sputum. Hemoptysis occurs in 50 to 70% of cases. You see, I told you that hemoptysis, this is very serious problem. It may tell you about some destruction like a TB or cancer, but in bronchiectasis, we don't have severe destruction of lung tissue. But nevertheless, in more than half of cases, we can see this blood in sputum, hemoptysis. And usually this is due to bleeding from friable inflamed airway mucosa. This inflammation causes development of very weak mucosa, which easily bleeding. And that's why patients expectorate this blood. More significant, even massive bleeding is often consequence of bleeding from hypertrophed bronchial arteries. I told you that in case of bronchiectasis, we have hypertrophy of arteries and veins, they become bigger, and they can produce, in some cases, even severe bleeding. They can produce severe bleeding. When a specific infections episodes initiates bronchiectasis, patients may describe a severe pneumonia followed by chronic cough and sputum production. So what does it mean? That if patient carry all the time bacteria's inflammatory process in his lungs, of course, it may lead to what? This infection spread to nearby tissues, weak tissues, not alveoli. As a result, we'll have pneumonia. And bronchiectasis, this is predisposing factor for development of pneumonia. Alternatively, patients without a dramatic initiating event often describe the necrosis or the insidious onset of symptoms. In some cases, patients are either asymptomatic or have a non-productive cough, often associated with dry bronchiectasis in upper lobe. Again, in other cases, if bronchiectasis placed in upper lobes, upper lobes easily drainage just due to gravity. All the bad stuff from upper lobes bronchi can be removed and expelled. And that's why a patient may have so-called dry bronchiectasis, dry bronchiectasis without accumulation of purulent sputum. And in this case, patient will have just non-productive cough, or even sometimes no symptoms at all. If bronchiectasis placed or situated in lower lobes, it's difficult to expel something from lower lobes. You can't stand on your head all the time. And that's why lower lobes bronchiectasis often produce purulent sputum, because for bacteria, it's easy to stay in these lower parts of lungs because it's very difficult to drainage, very difficult to evacuate. What else? What else? Dyspnea or wheezing generally reflects either widespread bronchiectasis or underlying chronic obstructive pulmonary disease. So dyspnea or wheezing may happen, but again, this is either when we have widely spread bronchiectasis, the widespread bronchiectasis, or maybe due to underlying chronic obstructive pulmonary disease, because COPD may cause development of bronchiectasis. With exacerbations of infection, the amount of sputum increases, it becomes more purulent, often more bloody, and patients may become febrile. So again, patients expectorate purulent sputum all the time, but from time to time it becomes more massive, patients will get fever. No, this is just new infection or more aggressive infection here, and we talk about exacerbation of infection. Now, such episodes may be due solely to exacerbations of the airway infection, but associated parenchymal infiltrates sometimes reflect an adjacent pneumonia. Now again, if patient with bronchiectasis presented with fever, with severe coughing, don't forget that it may be already pneumonia, and just send patient for X-ray to avoid misdiagnosing of such serious complication. Physical examination. Physical examination of the chest overlying in area of bronchiectasis is quite variable. Any combination of crackles, raunchy, wheezes may be heard, so dry rails, moist rails may be found. No, all of which reflect the damaged airways containing significant secretions. This is because we have bronchi with secretion. Of course, it will produce adventitious sounds like rails, raunchy, or dry rails, moist rails. As with other types of chronic intrathoracic infections, clubbing may be present. You know, clubbing, this is specific nails, the specific nails, which becomes actually half sphere shape, yeah? Or sometimes they tell that fingers becomes like a drumsticks. You know, drumsticks, they have widening at the end, the widening on the end, drumsticks. And actually, we still don't know why it's happened, this clubbing or drumsticks, but this is usual result of chronic infections, No, it may be found in some patients. What else? Patients with severe diffuse disease, particularly those with chronic hypoxemia, may have associated corpopulmonale, right ventricular failure. Now, amyloidosis can result from chronic infection and inflammation, but is now seldom seen. Yeah? Now, corpopulmonale again, this is usually a result of COPD, which cause corpopulmonale and cause bronchiectasis. Yeah? Amyloidosis, you know what does it mean? This is deposition of specific protein amyloid in different tissues, heart, lungs, liver, usually the result of long-lasting infections. But now we rarely see such complication, amyloidosis. Okay, let's see a few pictures. This is computer scanning of the patient. This is his left lung, this is his right lung. No, you know why left on the right side? Because you know this is like section, and we observe this patient from the bottom. And the result, this is heart, this is heart, this is left lung, this is right lung. And what we see, you see a lot of holes. This is not actually holes. This is computer scanning, like slide, and this is a lot of dilated bronchi, So you see that airways on the left have grape-like clusters of circular bronchiectasis. The grape-like clusters of circular bronchiectasis. You can find bronchiectasis here, but the most visible, this is on the left side. Actually, small holes, this is normal bronchi. You see, this is, when computer scanning, you will see bronchi, but this is normal. This is normal. And this is huge, this is still normal, but this is huge bronchiectasis on the left side. So, big question, what to do with such bronchiectasis? What about treatment? No, of course, first we should try to treat this infection. Use antibiotics and all this stuff. Because, no, on the other hand, we can't give antibiotics all patients' life. That's why, actually, bronchiectasis is a potential danger for the patient, hazard, because this is good site for infections, and because from these sites infections may spread to other tissues, causing pneumonia, abscess formation, and whatever you want. That's why it's better to remove this bronchiectasis from patients' lungs. How to remove? No surgery. But the problem is, okay, if you have localized bronchiectasis, which you found only in one lobe, for example, of one lung, no, okay, theoretically, in this case, you can remove this lobe. You can't remove actually only bad bronchi and actually leave normal bronchi. No, you should remove the whole lobe. And actually, lung is a very soft tissues. And surgeons, when they do this, they don't use scalpels, they use special electrical knives. And when they just burn lung tissue and smell in the operation hall like someone prepare, I know, some meat, very burning meat smell, smell of burning meat. But okay, if it's localized, let's remove. But if bronchiectasis occupy both lungs, you can't remove both lungs. That's why, unfortunately, we can't solve this problem absolutely. We can just do what? No, okay, find underlying cause. If underlying cause this is COPD, no, again, what you should ask, or what you should say to your patient, no, okay, stop smoking, because smoking provokes development of COPD. And do all actually antibiotic treatment and so on, trying to decrease infection process in bronchi, in bronchiectasis, because this is infection which lead to progression. Infection lead to progression. No, this is not, of course, cardinal treatment, or it's not absolute treatment. You can't recover, patient can't be cured completely or recovered completely. Can't be recovered completely. So again, the best way to avoid bronchiectasis, don't smoke. As a result, you will get COPD, and as a result, you will get bronchiectasis. No, I didn't tell you that actually sometimes we have congenital bronchiectasis, because some people already dealt with actually some bronchiectasis. No, usually this bronchiectasis is placed in upper parts of lungs, and in many cases they are insidious and bring no problems, because again, good clearance. No, this is just finding that on actually different investigations. Okay, this is main ideas about bronchiectasis and lung abscess. Bronchiectasis and lung abscess. No, and again, if you are finishing our lectures in pulmonology, the main pulmonological problem now in the whole world, this is COVID infection, COVID-19, which mostly affect lungs. No, and again, situation under control. You should follow all general recommendations. Try to wear mask where you present, especially in overcrowded places. Try to avoid these overcrowded places, some shops, some actually markets. So, and wash your hands, use antiseptics. No, and actually, as we told many times, this infection is not really dangerous for young people, means for you, but it does mean that you should avoid all actually measures of prophylaxis. All measures of prophylaxis. No, it's better to be protected, and in this case, we can avoid this disease. Okay, now if you have questions, please write in the chat. please write in the chat. Let's see what we can find in the chat. Again, you shouldn't write your names in the chat because again, you are detected automatically. If you have questions, please write these questions in the chat. Okay, any questions?
No questions, sir.
Okay, if no questions, so good luck. Our next lecture in propedeutics on 29th of October. The next lecture in propedeutics will be on 29th of October. So for today, lecture is finished.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.
Good luck
sir.
and goodbye. Good luck and goodbye.
До свидания.
До свидания.